Well, hey everybody, my name's Kevin and I'm a paramedic practice educator on Vancouver Island, and it's been a while since I made a video, so I thought I'd just get back into it, and coming up with a topic was kind of interesting. I've got a few things in mind for maybe future topics that have been suggested to me, but for this one, I thought I would just tackle something that came up a few months ago, and you may recall, you won't recall, but there was a memo that came out, and it was in the September Ops update. There was a memo that came out, or a clinical practice update. It's a catchy title, so I'd be surprised if you don't remember it. Interfacility IFT in situ thoracostomy tube maintenance, herein referred to as chest tubes. I know it just rolls off the tongue, but basically what this practice update does is it sets up EMRs and PCPs to carry chest tubes during interfacility transfers. And this was something that was a bit controversial before, because there is some discussion around whether PCPs and EMRs could carry chest tubes, as it is specifically stated in the EMALB regulations that chest tube management is technically an ACP Schedule II skill, which basically means CCPs can carry chest tubes and do things with them. Now, going back to this update that came, this came out because there's a lot of transfers that go on in the province where patients might have a chest tube, but it actually it's not really doing anything. It's kind of been in there for a few days, or it's something that's just draining off some fluid while the lung re-expands, or whatever the case might be. It's not there for an acute reason that requires any management. It's basically just draining maybe some air, maybe some fluid, maybe some gooey fluid, and it's just going to keep doing that during the transfer. And the reason for the transfer probably has nothing to do with the chest tube, but maybe is for something else, an appointment or a different specialty or something. So what we were finding is that those transfers would come back, and everyone would sort of default to, well, if they have a chest tube, then they need a CCP crew or a nurse escort to go. And it's really just not the case. There's a lot of cases in which chest tubes can be carried perfectly safely by EMR and PCP crews because they won't require any management. So what I'd like to do is just kind of talk a little bit about chest tubes, because when I thought about it, I thought, well, hey, if they can carry chest tubes now, that's perfect. They can just refer back to all the training they got in EMR and PCP school on how to deal with chest tubes, so it shouldn't be a problem at all. But then I thought, hey, wait a second. They don't get any training in chest tubes. So that's why we're going to talk about it a little bit. Just give everyone a little bit of insight into what chest tubes are, what they're doing, and if you're asked to move one, exactly what the steps are. So the first thing we're going to talk about is just what's in that practice update that I mentioned. So that practice update, and you can look it up in the ops report from September of this year, that practice update basically says that if there's a chest tube that doesn't require any management, which is sort of what's stated in the EMA regulations, is that chest tube management is a specific CCP skill, or ACP Schedule II, is that it can be handled by a PCP or EMR crew, because you don't need to do anything with it. Now, the big question is, well, how do we know that we're not going to need to do anything with it? And that's where it's highlighted in the memo that came out, that all of these need to be vetted by either the EPOS physician or what's called the CCPA, which is a critical care paramedic advisor. And that's a position that sits in PTCC, which is the Provincial Transportation Coordination Center. So handles all of the intra-provincial transfers and aerovacs and all that kind of stuff, and works with the other regional dispatch centers. There's a CCPA that sits there and sort of keeps track of a lot of the calls and transfers that are going on around the province, and is there as a resource for crews, for the PS, and sort of works with physicians and dispatchers to help just facilitate the clinical side of some transfers. Anyways, that position, or EPOS, will vet all of the calls that are coming for EMRs or PCPs in which there is a chest tube, to make sure that it's going to be safe, and that we're not going to put crews in a position where they have to manage something that is sort of out of their scope or out of their wheelhouse. Now, that being said, transfers, they're long in a lot of places of the province, and things change. So what I'd like to do is just kind of dive right in and talk a little bit about chest tubes. So yeah, here we go. Chest tubes are great. They go in the chest. They actually go back a long time, and the term chest tube actually comes from the Latin chestorium tubus, which came about in about the 4th century BC, and it was Latin by Greek physicians that were working in Rome at the time. Anyways, chestorium tubus has become shortened to chest tube. And because it's something that is so common and so prevalent, we're just going to touch base on sort of why we need a chest tube first, and then I'm going to show you the different types of chest tubes and the things that sort of are associated with them so that everybody can lay eyes on them. So yeah, what's a chest tube? Well, oddly enough, it's a tube that goes in the chest. And you know, that might sound a little simplistic, but it's kind of just true. It's a tube that goes in the chest. And you won't see much from an external point of view. Usually somebody with a chest tube, they'll have the tube coming out of their chest and there'll be a bandage there, and then it'll be attached to some sort of drainage collection or something like that device on the outside. But you're really not going to see too much at the site, assuming there's no sort of bleeding or weeping or something, which is a good thing to check before you go on a transfer with a chest tube, is take a look at the site, even under the bandages or around the bandages, and make sure that nothing seems weird around there, that there isn't signs of infection or pus or blood or anything weird around that site. If there is, of course, you need to bring that to the attention of the nurse or doc that's sending. But the chest tube is just going into the chest. And where is it going? Well, here's another one of my grade A awesome drawings, but the chest tube right here, the whole point is that it is going into a space that exists between the visceral and the parietal pleura of the lungs. So normally the lungs, there's two pleura there, and they're firmly attached to the chest wall. So here's the outside of the chest, and here's the lung. And the pink here represents the pleura. And normally they should just be stuck right together with a little bit of fluid in between them. And that's what allows the chest wall to expand and open up and pull the lung. In the case of somebody who requires a chest tube, for some reason, those pleura are separated and there's a bunch of crap in the middle. And that can either be air. This is very common in a pneumothorax. You have air that's separating and maybe pushing this lung down, and it's separating those pleura. And so air is a very common one. You can also have blood in a hemothorax where blood is collecting in there. But you can also have other stuff too, like a common one is pus or some sort of infection or something, or fluid can accumulate in a pleural effusion for a lot of reasons, and that might need to be drained as well. So there's a number of reasons why somebody might have a chest tube. I think we tend to associate them a lot with trauma, but that's not always the case. There's a lot of medical reasons why somebody can have an accumulation of fluid or potentially even air inside this pleural space, and it can require drainage. So what happens? Put in a chest tube, and that tube just goes simply right through the skin and the tissue between the ribs, typically, and past the pleura, and then into this space so that it can drain whatever is in there, air, blood, or goo, pus or whatever else it might be. So that's just a quick little overview of why that chest tube is in there. We don't need to get too much into detail about hemo and pneumothoraces, but the chest tube is in there to evacuate that, to allow the lung to re-expand, to hopefully get back to the point here where it's all fixed and all that stuff is gone from inside. So that's sort of the mechanics of the chest tube. What do we need to worry about from an actual PCP and EMR perspective on an interfacility transfer? Well, probably nothing. That's the whole reason that we're vetting these calls, to make sure that it's going to be safe. But it can be a little bit tricky just because this is unfamiliar equipment. And so I want to make sure that you guys are comfortable with it. So why don't we go ahead and just take a quick look at the different types of chest tubes you might see. There's kind of two. I'm going to show you those. And then we're going to talk about the collection devices you might see and what you can or can't do with them. So yeah, let's just take a quick look at those chest tubes. Okay, so talking about chest tubes, I'm going to show you two different kinds just so that you understand what they are. And it's pretty fancy. This is just the packaging that they come in. You might see these in the trauma room if you're in the recess room or wherever in your clinic or hospital. But in essence, what you have here is you have simply a chest tube that looks like this. Might be a little hard to see on the camera, but it's basically, yeah, it's a tube. It's a floppy plastic tube. And they come in different sizes and somewhat different lengths. The length markings are on the side. And then there's an end that goes into the patient, which is right here. And I don't know if you can see that, but there is holes along the side to help assist with drainage as well as at the end. And then there's markings so that once it's in the chest, you can tell how far in that chest tube is or how far out. So that's actually something worth noting on a transfer, is what number can you see? And at the end of the transfer, can you see the same number? And that'll help you understand if it's moved in or out. Sometimes they can migrate out. You never want to push them back in because you're just introducing the chance of infection or damage or something like that. It'll also say the size of them on there. Chest tubes are typically measured in French measurement. A French, for fun, is 1/3 of a millimeter is 1 French. So this one's a 20 French. It's a relatively small, sometimes these come in big honking like 34 French things that are big giant tubes that they'll put into trauma patients with big hemothoraces to try to evacuate all that blood out of there. But on the other end, it simply just flares open a little bit and it can be connected to one of the drainage devices and the stuff we'll talk about in a little bit. But this is the chest tube. It's nothing fancy. If you see it coming out of somebody's skin, the only thing you're missing is just that. It's just sitting in there between the lung and the thorax. So yeah, nothing too fancy on the chest tube there. The other type of chest tube that I want to show you guys, and something that you might see in more chronic patients or patients with maybe draining just a small pneumothorax or maybe a little bit of pus or accumulation, is a chest tube, and it kind of looks like this. So it'll look different on the outside. You'll see something that looks a little bit different just mechanically sitting on the outside here, and there might be this little piece of thread or string sticking out of there. So this might be sitting there as well. And on the inside, you can see that it has this little curl to it, and that's what the string is there for, is actually to make sure that it stays curled and in the curled position. And this is just really gentle, right? So it can sit there. It's not going to poke the ribs. It's not going to hurt the inside of the chest. It's not going to poke the lung. It just, it sort of hides any sort of blunt tip of the chest tube, and it's much smaller and less painful to insert. So it can be put in for things, people with pleural effusions, maybe with cancer or something, or a small pneumothorax, or a little bit of small hemothorax, whatever. If somebody doesn't require a big, large volume drainage, they can put in a small one. Now, the thing that I wanted to tell you about this is because of the shape of it, looking like that, they actually call these pigtail catheters. And I think that makes sense just looking at them. They look like a little curly pigtail. So if you hear the term, yeah, they have a pigtail in, which might be a common phrase you hear, this is all they mean. It's a chest tube still, but it's a smaller one, and it just has this little curve at the end. That's the only difference. So still a chest tube, nothing crazy. And then again, it'll just be connected to the drainage device. So what we have is we have those two types of chest tubes. We got the sort of bigger ones that can be used more acutely in trauma and stuff like that very commonly, or we have the smaller pigtail one that can be used in various situations as well. And in trauma, they might elect to put one of these in too. It's sort of up to the physician. So just depending on exactly what the nature of the injury is in the chest. So that's the two types of chest tubes you might see, and both of those could be sticking out and into the collection device. So let's just go ahead and talk about what these could actually be attached to, and then we'll just touch base on what management actually means of a chest tube and what a PCP or EMR crew should or shouldn't do. Cool. Okay, guys, so what I want to talk to you about, the first thing I want to cover off is something that's called a Pleurovac. And that's a trade name, Pleurovac. It says it up there, but this is kind of the most common one of these collection devices attached to a chest tube that you'll see. There might be other brands out there, depending on the health authority, but for the most part, these are pretty common. And even if it's a little bit different, it'll sort of have the same functionality to it. So I just want to take you through what this is, because if you're asked to move a chest tube, there's a good chance that it might be attached to one of these things. You'll have to take this along with you as well. This can be a little bit intimidating if you don't know what's going on. So I'm just going to walk you through the parts of it and the steps of it so that you understand it and you know sort of the key features of what to look out for to tell you if there's a problem. So first of all, the Pleurovac and this big device here is it's just a giant collection chamber. So what it is it gives all of the goo or blood that's being collected from the chest in the chest tube somewhere to go. So we can measure it, see it, and sort of see how much of that is coming out of the patient. The other thing that it'll do is it'll actually provide a seal so that air can come out of the chest tube and out of the chest, but that air can't go back in. So all it really is, I'm sure everyone's heard of an occlusive dressing, 3-sided dressing, our chest seals that we use to make sure air doesn't go back in on somebody with a penetrating trauma to the chest. This is basically just a continuation of that, where you're putting a one-way seal in there, in this case just using some water, in order to make sure that air can't come back into the chest if the situation is such that air could be drawn back in, like with negative pressure through normal breathing. So we'll talk a bit about that. But all this really is simply just a collection chamber, and 3 parts. There's sort of a collection chamber, there's the water seal to actually make sure that air can't go back into the chest. And then there's actually the ability to provide suction on here as well. And you might provide suction to this and to a chest tube if you want to make sure that you're getting the stuff out of there. It's something that's not just going to come out freely. So blood, or maybe pleural effusion, which is mostly sort of watery, or a little bit of infectious stuff, or maybe even air and sort of a persistent pneumothorax. But for the most part, this is able to provide all of those things all in one one contained piece of equipment. So we're just going to talk about that real quick, but we're going to start at the patient side. So we talked briefly about the pigtail catheter, the small one, and then the chest tubes as we have them. So I'm just going to use the chest tube for the example. So we'll say that this is in a patient, and the next thing that'll happen is they're going to want to attach it to some sort of collection device, because to just stick a chest tube in the patient and have it sitting there, well, it's not really accomplishing all that much, is it? Because you could actually just get, you might get some stuff out, but you can also pull more air in, germs. It's not good. So these come, they're all sterile wrapped, and the hospital set them up. And they come with everything you see here. So they get this big long tube, so it can sit on the floor is usually where these sit, next to the patient. And this big long tube simply connects right up to the chest tube. So they'll take this and they'll insert this. There might be an extension that they use as well or something like that. But for the most part, you just attach this. And a lot of the times these will be wrapped up in that pink sort of waterproof tape as well, just to help secure the connection. So you'll see them taped up. And then this is now basically sitting in the patient, but now it's connected to this drainage device. And you can see that the hose goes all the way around and then pours in the top right here. So right now, we'll just assume that perhaps there is some blood or something like that, a hemothorax. What's going to happen is all these numbers on the side here just measure how much blood comes out. So it's going to start to fill up this side of the chamber, then it spills over inside and fills up this side of the chamber, this one, and then up to 2.5 liters. First of all, if you have 2.5 liters of blood out of your chest, that's not good. So yeah, this is a chance to sort of monitor how much of that comes out. The next thing that happens, even if there was just air, is that all that air just goes through there as well. And then it comes out and actually hits the water seal here. So the point of the water there is to prevent air going back into the chest, or prevent the buildup of air. It allows air to escape the chest tube, but doesn't allow it to come back in. So what you can see in a patient, and I should qualify this because it really depends on if the patient is breathing on their own, or if they're connected to a ventilator, being bagged or something like that. So if you have negative pressure, positive pressure, it can really change how the air moves in and out of the chest, not just in the lung, but also in this space because of the pneumothorax or whatever. But for the most part, in interfacility transfer, where we're worried about PCPs and EMRs moving something, we're going to assume that they're not intubated and that you just have somebody who's breathing on their own. So when we breathe on our own, take a big breath in, we're creating negative pressure in the chest. That's what pulls the air into our lungs. We create negative pressure and it pulls the air into the lungs from the atmosphere, from the outside air. So if I do this, but I also have a tube here, that negative pressure will also pull air in through that tube and back into the chest. Well, that's what we don't want. So what we have here is this little water seal, and what that does is that actually prevents that air from going back in. It tries to draw on the water, and it can't, because the water is obviously a little bit heavier, and it can't pull the water through. So air will still go in through the mouth, but it won't come in through the chest tube. But if I have positive pressure in here, like that buildup, like a pneumothorax, and air is building up in there, so there's a lot of pressure in that pleural space where the pneumothorax is, this will easily allow that air to escape. You can actually sort of see that. Basically, if you take this and you look down here where this little water seal is, if you had any kind of a pneumothorax and positive pressure, you're just going to see that air bubbling right there. And this is actually how you tell. They call it an air leak. So if you have an air leak, you're going to see those bubbles forming right there and coming, and that means that there's a pneumothorax and air is coming out of that pneumothorax, which is the whole point, right? We want it to come out of that pneumothorax. So, seeing an air leak can be a good thing, but in an interfacility transfer with a PCP or EMR crew, you probably shouldn't be seeing too much of an air leak, because that means that there's an ongoing pneumothorax that could potentially decompensate. So that's a question that the CCP advisor or the EPOS doc will probably ask, and you'll have that discussion about whether there's an air leak. If you hear that term, that's what it means. Is there evidence that air is coming out of the chest, out of the tube, and bubbling through here and going out to the atmosphere? So we have the collection chamber. We've got the red part here, which is basically that water seal that keeps the air going out but not coming back into the chest tube. And then up here, this is actually the suction. So this is where right at the top here, this can be attached to suction in the hospital, like one of our suctions in the car or whatever. And it can be adjusted. You set the suction. There's a little float that pops up in this window to show you that the suction is on, and the amount of suction can be adjusted right here. The application of suction to a chest tube is management. So chest tube management includes applying suction to the chest tube. So PCPs and EMRs cannot carry a chest tube, a drainage device, anything like that requires suction. If it requires suction, that is management, and that's going to need a nurse escort or a CCP crew to move it, basically. So that is sort of the line. It's pretty easy. If it needs to be to suction, then that's a no-go for a PCP and EMR. If it's not to suction, this will usually be down on the floor by the patient, and the usual terminology for that is that it's just on gravity or to gravity. So that chest tube is just to gravity. And what that means is that it's just lower than the patient. So if there's a buildup of fluid or blood or anything like that, that it'll just sort of drain out on its own. And so it doesn't need active management. There's not so much in there that we're worried about the patient's physiology. It's just doing its thing, draining an infection, a little bit of fluid, whatever it might be. And that's cool. It can do that. Or there might be just a little tiny air leak or something like that coming out, not to suction, but they're just maybe at the last stages of healing their pneumothorax or something. And every once in a while, a little bit of air comes out. That's cool too. But that is all something that you can discuss with the EPOS doc or the CCPA. And you can reach a CCPA, by the way, through the paramedic specialist, through clinical. So you can just have a discussion with the PS and then bring on the CCPA or the EPOS doc to sort of discuss the chest tube. It's probably actually already been flagged or noticed by somebody as well, but you really need to touch base with them to have a discussion about what you're seeing with regard to this thing. So yeah, that's just a quick overview. Maybe not so quick, I talk too much, but that's a quick overview of what the actual Pleur-evac is. So this collection chamber, yeah, it just looks like that, front and back. You know, there's not too much to it. It's three things. It's a collection device, it's a water seal to make sure that air goes out but not in, and it's the ability to apply suction, which is a CCP or nurse skill. The last thing I kind of forgot to mention is actually when a patient is breathing, you're going to see this column of water move up and down as they breathe in and they breathe out. It's totally normal because as they breathe in, they're creating negative pressure to pull air in to breathe, but that negative pressure is also being pulled on the chest tube in the system. So it's going to pull a little bit of that water up here, but it's not going to allow any air. That's the whole point of the water seal. So totally normal to see a variation in that with respiration. In fact, you should see that. So yeah, there you go. In terms of the transfer and what really matters, well, it's pretty simple. Like I say, check the site, make sure nothing is weird. You might want to check the depth of the chest tube to make sure you know how deep it is and you can tell if it's migrated or not during the trip. You want to make sure it's all nicely secured and taped up, and work with the nurse to ask these questions. And then, take a look at what's in the chamber and be sure to be forward in asking what's going on with the Pleur-evac in the chest tube. Like, what are we draining? What's the purpose of the chest tube? Has there been a lot of change recently? If they just put a brand new one of these on, what was in the last one? Because if it was 2.5 liters of blood, it might not be a super stable patient, so that might not be appropriate for that trip. Has it required any sort of other management? Sometimes you get clots forming in this, and you need to have, it needs to be flushed. Sometimes people talk about milking these, where they try to break up the clot and milk it down, but even pulling tight on this can actually change the pressure a lot and actually cause a lot of damage within the chest itself. So all of these things are things that you want to kind of avoid. There's a clamp on these, so you can clamp the chest tube. That's something that would need to be ordered by the physician and discussed with the CCPA or the EPOS, because as soon as you clamp a chest tube off, just like the IVs, as soon as you clamp this off, well, that chest tube isn't doing anything anymore. It's not going to let any air out. It's not going to let any fluid out. So clamping a chest tube can be a little bit tricky as well. The pigtail, the smaller catheters, these could also be attached to a Pleurovac. They might be attached in some cases to something else, and that's fine. It's probably just a collection device. And the other thing I'll show you right here is that very commonly for a small pneumothorax or something that's just being left to sort of the lung to expand to get back on track, this actually might be attached to what's called a Heimlich valve. And the Heimlich valve just looks like this, and it's just basically a plastic tube. You may have seen these before, that the tubing can attach to from the chest tube, and it just lets air out of the little rubber piece inside of this thing, but it won't let any air back in. So it's no good for draining fluid, but for a pneumothorax, which is where it's just air, this will serve the same function of letting air out, but not letting air back in. So it's a very simple device that people might have attached to them. And that's great. If there's no fluid or no issue, these are pretty simple things. It's basically just that sort of three-sided dressing or that chest seal, just looks a little bit fancier. So yeah, you just want to take a quick look at that and make sure it's attached and seems functional, and there's kind of not really any problems with it. For the most part, they kind of just do their job. And those will be on sort of those subacute patients or patients that won't require management is the idea. So we've talked about the types of chest tubes. We've talked a little bit about why they're in there. We've talked about what this thing is, the Pleurovac, or sort of a similar device. So when it comes to moving those chest tubes for PCPs and EMRs, just do your due diligence. You monitor the patient. If anything changes, you're going to obviously want to note that and maybe give a phone call back to the CCPA or EPOS or the paramedic specialist. And for the most part, these transfers should be vetted and should be pretty safe. But when the patient's in your care, it's still your job to monitor them. What are you going to see if there's a problem with any of this? Well, the first thing you'll probably see is a little bit of respiratory distress, either an increased work of breathing, a complaint of dyspnea or shortness of breath. You might see, changes in the saturation, sort of in the late stage, increased work of breathing, accessory muscle use. All the things we'd associate with sort of respiratory problems is what you would see. And you're also going to want to note if this was nice and clear and nothing's going on, and all of a sudden you start to see some blood or something coming down into the tube, and that's new, it's like that's definitely worthy of a phone call, or maybe even returning back to the sending site if that's closer, or looking for sort of that plan B or a meet along the way with a crew if one's available, a higher trained crew. So those are pretty unlikely. These should be pretty safe transfers. I hope that helps you guys just understand what a chest tube is and what you're seeing. The last important thing of note is don't tip these over. They don't like it. The water comes out of the seal, doesn't help. Yeah, it's happened. Trust me, I've done it myself, but it's kind of awkward if these get tipped over. So they have a little stand. For the most part, they sit on the floor of the ambulance just fine. And there's even little hooks on the side that can hook onto a bar or like the bottom of the stretcher or something when you're moving to keep it down below the patient. So yeah, those are the features of everything there. If you have any questions or if I haven't explained something well, that's my bad. Feel free to shoot me an email or shoot an email to your practice educator, and please engage and ask questions. So hope that helps. We'll look at some other videos that are hopefully more fun. Sorry, yeah, I'm just a little, but hopefully a little bit more fun in the future. And yeah, thanks very much for listening. So have a great day. Bye.